I think we're good. I'm asked to discuss conflicts of interest when we talk about urinary infections. I have many conflicting interests. I'm interested in quality improvement and teaching at my hospital. I'm interested in training our ID fellows. You can see how serious they are. I'm interested in climbing tall mountains. I'm interested in spending time with my very happy family. The good news is they do grow up to be happy people. No financial conflicts of interest. It's antibiotics. There's no money in it. That's the whole problem. I am being paid an honorarium for these remarks that will be donated to this project, which is called Pallergy. It's an app that we're building. It's not yet ready to download, but we'll go through this in the second remarks I have with you in about an hour or two from now. Your pal in the fight against bogus antibiotic allergy, so thank you all for supporting that. Will there be discussion of off-label antibiotics? Yes, of course. Almost everything we do in ID is off-label. That's part of the problem as well. So the objectives are to be very comfortable in the next hour becoming clear about what causes and how we treat recurrent UTI, to associate the cause and treatment of hospital-associated UTI, and then talk about UTI in people with indwelling catheters. So that's what I was asked to talk about. Almost all of our time will be spent at the top bullet, because recurrent UTI, whether it's in the hospital or in clinic, in your private practice, etc., very, very common issue. We're talking about Rudy, not Rudy, but RUTI, recurrent UTI. This is a talk about Rudy. Okay, so recurrent UTI is an incredibly common problem, and one of the biggest issues to figure out, of course, is whether you think it's truly infection, or could it be something called ASB, which stands for asymptomatic bacteriuria. It's a huge problem because in clinical practice, in family medicine, and primary care, coast to coast, it comes up all the time. We know that women who have, especially young women who have a UTI, 1 in 4 of them will present again to care within a few months for a second course, for a second concern that they may in fact have UTI. It's usually biggest risk in the first weeks, but it can be for a period of months thereafter. And in general, if we're talking about recurrent UTI, especially in women, that means they're having 2 or 3 episodes per year. Some of your patients will have a lot more, and some less frequently, but that's how this averages out. What are the risk factors for UTI? They are the same as the risk factors for recurrent UTI, and they're listed here. A lot of what we understand about UTI actually comes from the University of Washington. We're really fortunate to have Dr. Walt Stamm and Dr. Ann Stapleton, Dr. Mac Hooten, Dr. Cal Gupta. They all did a lot of this important formative work in epidemiology and studies at UW. So what you've been told in medical school and such, we think it's really true. These are the things that can be associated with UTI. And I think, as you'll see here, we're talking primarily about women, and we're talking primarily about women in those 2 big groups. Are they before menopause or after? There are problems with this distinction, but because the physiology is different, that may be one way that can help to frame the way we think about these risk factors. And I think if you look here at the list, you'll find that so many of our patients will fit into 1 or more of these risk factor categories. Indeed, that's why we have so many women complaining of UTI. But again, is it infection or is it asymptomatic? So important to figure that out because, of course, the treatment is completely different, and there's major implications for your patients. Some of the myths that we like to bust when it comes to the patients who come in complaining of UTI. Why do you think you have a urinary infection? What are you going through? If they say, I know I have a UTI because my urine is a darker color, because I smell a different smell to the urine. These are true things, but they're not related to infection, or at least usually not. This could be related to diet, to hydration status, medications. There are other things that can drive the appearance of the urine. Similarly, if a patient complains of vaginal discharge, they may misattribute this as UTI. We know, as prescribers and physicians, that's a different issue. It has to be dealt with, but it's not a UTI. What about urgency? I got to go right away. I really need to pee. I know it's a UTI because I have to pee very frequently. So not everything that is urgent is actually a urinary infection. And as our patients get older, men and women, but especially women, get that detailed history. When you say there's an urgent need to urinate, ask about the timing of the day. For some patients, it'll be a classic thing, especially in our postmenopausal women and our older patients. You know, they'll come home from a walk, they go to the store, and they put the key in the lock of the door, and that's when they have to pee. That is not a UTI. That's a biological issue with respect to the brain detrusor axis. So they need biofeedback, they need help. They have a twitchy bladder, but it's not a urinary tract infection. Antibiotics won't fix it. Delirium, one of the classic things that we worry about a lot, at least when I was in medical school. We were all trained the same. If someone has an altered mental status, male or female, and they're older and they can't give you history, check the urine. This is a problem because if you look in the pee, something may eventually grow, right? You only know 3 things in life: death, taxes, and the positive urine culture. It doesn't help you. It's all about trying to figure out what else may be driving this. And that person may have a UTI, but there are so many other things that are more likely to drive their delirium. Surveillance cultures. Well, I'm just going to check the pee because the patient asks, can I have a urine culture? Well, no, probably not. Unless there's a high suspicion for UTI, this can be a perilous problem for the reasons we were talking about, because the reliability of that data totally depends on your pretest probability. It's like looking for a PE. Do they still have PEs? When I was in medicine, they have this thing called the pulmonary embolism. You had to decide whether you were going to scan them or not. I guess it's still a thing. Anyway, it's like that with UTI as well. You really want to think about this before we send that test. Only test when we suspect true UTI. How to interpret those tests? Very fraught, very problematic. I hate testing for UTI because it's such a pain. So one of our faculty members, when she was a resident, Amanda Shepard, and I put this table together. We're looking not at odds ratio, but likelihood ratio. How likely is it in real life when you get a positive test or a negative test that this really associates out with true UTI? And you've got this reference here, but what I would point out is the numbers that you see, this likelihood ratio through the roof, if you have both a positive nitrite and a positive leukocyte esterase, it's got to be a UTI. You will see these tables, including in our manuscript. That data comes from ambulatory care in otherwise healthy, uncomplicated young women. This does not, NOT not, translate to people with a catheter, does not translate to people who have asymptomatic bacteriuria, people who are postmenopausal. They just were not included in this calculus. So I think if you have a high suspicion, if she is coming to you, you think it's UTI and the testing shows that, you're probably right. But if you have doubts, do not be misled by any positive test. Your clinical suspicion more important than any UA result. What about cultures? What if we do grow something from the urine? I like this study very much. This is Mac Hooten and Ann Stapleton looking at the experience of women in Seattle at our University of Washington. And these patients came to a primary care clinic complaining of symptoms concerning for UTI. And they did something that was very smart. They had them get a midstream clean catch. That's our gold standard, right, for when we're going to get a urine culture. Cleanse the area, pee a little bit, then catch some urine, then pee again. And the concern was that this is still a fraught problem. It's difficult for patients to do this in some cases, and how reliable is it when we actually get something to grow from there? So they actually did that, and then they catheterized the patient as well. So you have both a midstream and a cath at the same time. And what did this show? If there is a midstream catch that shows E. coli, that's your pathogen. But if that midstream catch also grows something else, especially a gram-positive like enterococcus or strep, in the catheterized specimen that was almost never there. So just going to show the E. coli, that's your apex predator, that's the bug when it comes to UTI. And if you see something else that's different, especially in someone who does not have a catheter, it's probably not actually in there. You don't have to catheterize your patient to figure this out, but knowing the statistics really helps. So E. coli, that's what we want to treat when we choose to do so. And if there are other things, especially gram-positives, usually they can be ignored. If the patient is septic, if you're admitting them to the hospital, if they've got a catheter, it may all be quite different. But this is usually the way outpatient. So what if you go through with this whole process and you are not convinced that your patient has UTI, and yet the patient is convinced that they do? The patient is always right? Well, not always. So as a trained medical professional, you are probably correct, but they have to understand why you are concerned about giving antibiotics unless they are necessary. And in the next hour, I think we'll hear from Dr. Lewis about the importance of antimicrobial stewardship and why we want to be good stewards, good shepherds of this precious resource. So we always tell people about avoiding harm. I don't want to give you antibiotics unless you need it, right? So diarrhea is a common thing that people complain of. Vulvovaginal candidiasis, the yeast infection, allergic reactions. There's this issue about cognitive problems. Did you see this paper recently? It was interesting. Long-term antibiotic use in midlife is tied to later cognitive decline in women. So I don't know what to make of this. This is a huge, big data, meta-analysis type of study where Basically, they found exactly what you see there. Women who are more likely to get antibiotics are also more likely to develop dementia. It does not mean that it's the cause, and I can't quite figure out why that would be. I guess maybe with the whole thing about benzos, it kind of makes sense. I'm not sure this is true, but it's a great talking point. We have uncertainty. There's big data to suggest this may be yet another unanticipated, unexplained possible association versus cause. So that negative stuff doesn't really work for me in my own practice. I like to be more positive with patients, right? I want to maintain this effect. You are going to need treatment for a UTI or a respiratory infection or a skin infection. You may need antibiotics. When you do, I want to make sure we have options. So let's hold on to this spectrum without using it too soon so that we can later on give you something to help. Avoiding cost, people don't seem to care much about the cost of antibiotics. That doesn't work for me. If you do decide to treat, how can you go? The scenario would be that you have uncertainty about UTI, your patient is convinced that they may need antibiotics, you have the UA, which is inconclusive, or it's trace leukocyte esterase, no nitrite, not looking classic to you. Is it okay to wait for the culture to grow? Yes, yes it is. The concept here is to say, okay, go home, here's the prescription, or let's talk again in 24 hours, see if you still have symptoms, and if so, then we can treat. This can reduce the unnecessary use of antibiotics. The patient, we hope, would feel validated, heard, that they have an exit strategy, right? They know what is happening, and they know that you've taken them seriously, and you are willing to treat them, but only if necessary. So this has been looked at statistically, and this does reduce the prescription of antibiotics, and it doesn't really seem to hurt people. No increase in this particular study, progressing to pyelonephritis. Nobody went into septic shock, etc. Things were generally very well tolerated. So I like this idea very much. If we do decide to treat, how should we do so? We're still trying to figure this out, right? So the latest guidelines that we have nationally are 10 years old. And I think they need to be updated. We've spoken about that in this particular meeting before. I do not know when these new guidelines will be forthcoming, but they're not going to look very different from this. What the US guidelines tell us is that we should use either nitrofurantoin or trimsulfa or fosfomycin. Not in that order. They're all considered to be of equal benefit and equal weight. I would be so appreciative if you would, by raising of hands, who in the last year has prescribed fosfomycin for their patient ever in your entire life? Okay, I don't see any hands going up. And that's pretty common, or maybe one hand, thank you. It's pretty common in my experience that fosfomycin is very much less commonly used. Remember, this is a 3-gram sachet. It's not a pill, it's not a liquid, it's a powder. You tear it up and dump it into a glass of water, and that's it. One dose, and you're done. It's a beautiful way to go, except it causes diarrhea, headache, and it costs $65 per dose. So that's why you're not using it, and that's why pharmacies don't stock it. But I want to promote that idea in your list of options because you may have someone who won't take nitro, you think they're allergic to sulfa, or they may be resistant in their own microbiology. Don't forget about oral fosfomycin, and I want you to do that, please consider doing so, before reaching for Cipro or Levo. Ciprofloxacin and levofloxacin are no longer permitted by FDA for the treatment of acute uncomplicated bacterial cystitis. It is against the rules. One of the many black boxes in the quinolone class, and that's because the toxicity risks generally outweigh the benefits. You can do it if you cannot do these other things, that's fine. Medical legally, to protect yourself, please do document that in the chart. I went through guideline care, couldn't do it, therefore I'm going to reach for this other treatment. But that should no longer be our first reflexive go-to option. Levofloxacin, a wonderful drug for pyelonephritis. In kidney infection, I love the Levo, but I do not like to use it for the bladder because these other options are generally a good way to go. But again, back to Bactrim. We're only supposed to use trimsulfa if our local resistance rates are at or less than about 20%. At least that was the guidance 10 years ago. By any chance, does anybody here know your own local resistance rates to trimsulfa? We have a huge gap in our statewide, and indeed it's an embarrassment nationally, that we are not providing from public health authorities, we're not providing prescribers with actionable data based on zip code, based on where you practice. Most people don't know their own antibiotic resistance profiles. It's really a shame because you're the ones who are doing the work. And by the way, you're also enriching the labs when you keep sending them the P. They make money. They need to give you back that data. So we're very fortunate in the state of Washington to have Dr. Marisa D'Angeli and also Jessica Zering, who's working with her now, trying to get an antibiotic profile out that's free, open source, and publicly searchable and available. So hopefully coming to a website near you in the near future. And I think the guidelines may reflect this soon enough as well. I would emphasize these are short courses. When you do choose to treat for UTI, remember, less is more, shorter is better, and I'm happy about these reduced durations of antibiotics, different from when I was in training. If none of the things you saw above will work, and you are looking at, because of resistance, because of toxicity, or because of some drug interaction, what else have you got? Well, traditionally that's been IV ceftriaxone, which is not a good look and will not work against something called extended spectrum beta-lactamase E. coli. ESBL E. coli is resistant E. coli that is treatable essentially with carbapenems, like ertapenem. The problem with ertapenem is it's IV, and so it's just been a huge issue for us in our practice. Therefore, so exciting to know that we now have an oral carbapenem, which is in development, called tebipenem. Tebi is basically oral erta, and it's been in the works for a very long time. As you can see, it's dosed, 3 times a day, and it is cleared through the kidneys, and it may be no requirement for change in liver disease. Having said so, does it work? Well, here's the phase 3 trial, which you may have seen published in New England Journal not long ago. This particular trial, they had people who were, this is a great trial, it's a double-blinded, randomized controlled trial, tebipenem versus ertapenem for people with complicated, not cystitis, but complicated UTI because of anatomic factors, including pyelo. And as you can see, there was just no difference. It was just as good, non-inferior to ertapenem. And there was almost 1,000 patients enrolled, and so this is awesome. It doesn't get to look any better than that. And so what a kick in the teeth. And by the way, no difference in adverse events. And so the conclusions of the authors, this is just as good as ertapenem. And what a kick in the teeth when FDA said, nope. The FDA ultimately concluded that your phase 3 trial, called the ADAPT trial, was insufficient to support approval. Additional clinical study will be required. I have not reviewed that letter, and I've not spoken with the clinical lead, Dr. Talley, although we trained her at UW. I should reach out to her to figure out how quickly they're going to be able to respond. I cannot imagine what else they're looking for. It drives me crazy that they want more information, but there it is. Soon enough, I hope you'll have access to oral tebipenem. When you do, in lines of what Dr. Lewis will talk about in the next hour, please use it as directed and not to overuse it for other syndromes. It's going to be a precious resource for us. It's exciting times. We're just not quite there yet. Resistance is on the rise. This is part of the problem. It's part of the reason why I'm excited and enthusiastic about tebipenem. You may have seen this recent paper by Dr. Lodis and others looking at more than 150,000 cases of people coming in with urinary infection to urgent care and emergency departments. And well, the resistance are there. These are not susceptibility, this is resistance. So the resistance rates in these patients presenting to urgent care was substantial. And this probably roughly reflects what you will see in your own practice. And I say that because this is a nationwide data set. So this is the reality of what we're seeing. And if we want to reach for fluoroquinolone, I mean, you might get there in about 80 to 85% of cases. Who's going to be in that other percentage? You may not know. This is why we need new energy and new excitement and new technology for new medications in urinary tract infection. I'm going to conclude the treatment portion by giving you a humble reminder, which I think we all know intuitively from our own experience, but I just want to place it very clearly. The number needed to treat for uncomplicated acute bacterial cystitis is probably 4 or 5. I'm going to say it again. For every 4 or 5 women you treat, 1 actually needs to be treated. The others will self-resolve. They will get better spontaneously. The urinary tract, for all of its problems, it does drain, which is a beautiful thing. Very different from an abscess or an endocarditis where you're stuck with the infection. Every time the patient voids, the infection is washed out to sea. And that's why, well, humans have been getting UTI since forever, and we usually have survived it. So I'm not saying not to treat someone with symptomatic cystitis. I think you should. I've never had a case. It looks miserable. But just to remember, if we feel like we're under-treating, you are probably still over-treating in your own practice, as am I. So can you do this over the telephone? Yes, and I wanted to give this referral, this guideline to you, not just because we're doing so much telemedicine now, thank you, COVID, but also because this is something that was actually studied before COVID-19, that you can handle these patients over the telephone, usually safely, if they know their symptoms and you have documented previously that their symptoms are associated with UTI. Many of these patients are trustworthy. You can probably handle this at least once over the telephone without having them come in for culture. And the risk factors when we would say, geez, I really do want to see, would be patients who are older, those who've had multiple rounds of infection that isn't getting better, people who have recently traveled, the obvious risk factors for resistance. When we do this, patients come into the office less often, better resource utilization, and patients seem to like the idea that they could call their prescriber, get a prescription, and go, with all of the caveats that we've been talking about. So, what about prevention? I'm going to switch from treatment to prevention. I hope that that's suitable. This is something that really caught my attention when it was published just a few years ago, because I learned in medical school that for acute uncomplicated bacterial cystitis in women should drink more water to prevent recurrence. Is that true? And the answer is yes. It is totally, totally true, and it's now been published, and it's beautiful. These are 140 women with recurrent UTI. They happen to live in Bulgaria, and they were interviewed. How much water do you drink? And these are the women who they live like a dromedary. They just don't drink water. They drink less than 1.5 liters per day. I won't ask for a show of hands who drinks less than 1.5 liters per day. I don't know how you live. When you have a patient with heart failure, we restrict them to 2 liters per day. These are women who just don't drink much water, and they had recurrent UTI, and they were randomized to either continue with their camel-like lifestyle or drink more water. And then they were followed medically and microbiologically to see what happened, and lo and behold, the women who drank more water had less UTI. That's what you see reflected in the bar graph here. So I love this study so much, because when it comes to interventions, which we will talk about soon enough, this is one that is cheap and easy. And I just tell patients, after you urinate, look in the toilet. It should be clear, or a very, very light, dilute yellow color. If it's dark, you probably need to hydrate more. That's the simple dipstick for most of these patients, and it's easy to do, and it seems to work. What about association with sexual activity? Yes, that is a factor for some of our patients. This is usually categorized, as you see here, as a premenopausal issue. Spoiler alert, there is a sex life after menopause. This is not just for premenopausal women, although it's more common in that group. So patients will tell you, I know that I'm going to get a UTI every time that I have sex. And so that could be with a new partner or a long-time stable partner, but it's usually with a new partner. Statistically speaking, that's the case. We don't know why this happens, but there's different theories about why it does. It's a very real association. What do we do for these patients? It can be a hardship. It can really impact their quality of life, et cetera. So what we try to emphasize is that this risk tends to decrease over time. It's not the end of their sex life. And yes, there is a statistical association for benefit for patients who would receive pericoital prophylaxis. The way this is usually done is a dose of sulfa right after sex, although statistically speaking, microbiologically, mechanically, you would probably want to give it right before sexual activity, but it hasn't been studied that way because people aren't usually in the mood to take antibiotics at that phase of their activity. But anyway, this is the benefit that you can see, and the benefit in recurrent UTI, as I think you'll agree, very similar to the slide I just showed you, probably the same as the benefit of hydration. I emphasize that because if patients come in asking for pericoital antibiotic prophylaxis, it can be offered. I always start with hydration first, and I tell them it's just as good. There'll be no yeast infections. It's good for your body generally as well. And if your patient happens to be using a spermicidal jelly as a form of contraception, they should be counseled that this is absolutely a big independent risk factor for recurrent UTI. We don't know why. We assume that it's just nuking the healthy microbiota in that part of the body. They should consider possibly changing their method. If you do choose to go, it doesn't have to be sulfa, and this table put together by Mac Hooten and colleagues, if you look at an up-to-date, that's where you'll find this. You do have other options too. Your patient may be sulfa allergic or unwilling or not eager to take it. Number one, you could use nitro or others. Number two, you can use, I think you'll see here, trimethoprim alone. So trimethoprim, it's not as potent as trim sulfa, but for this indication in this body compartment, actually it works. So even sulfa allergic women can receive trimethoprim as monotherapy. It's not something that most people prescribe, so I wanted to call that out to you so you know that that is an option you could consider in your practice. If you do so, please consider only doing it for a few months at a time. Because again, I think due to social activity and behavioral activities, that risk may decrease over time, although I'm not quite sure why. That's premenopausal mostly. What about postmenopausal? Well, the body changes as we age, and as there is local loss of estrogen effects in the vagina, that has implications, we think, not only for the integrity of the skin and the tissue, but also as a healthy home for the beneficial microbiota that should be there, which we'll come to in just a moment. So, giving people hormone replacement therapy, I guess that's a thing, gives you breast cancer or uterine cancer. You may not want to give people a pill. This is for local replacement. So local replacement just where it's needed, for example, either as a cream, which can be applied externally, or as a ring, an estrogen-eluting ring. If you choose to go this way, please counsel your patients and let them know that this takes time. They should not expect their UTIs to go away permanently, and they should not expect it to happen overnight. This takes months to reconstitute the healthy situation that they're trying to put back into that part of the body. The benefits may take months to appear, to encourage people to do this. If all this fails, and you're sick and tired of it, and the patient's sick of it, and they like you, but they don't want to come see you, you will be sorely tempted to give them antibiotics as continuous prophylaxis. This has been studied, although not nearly as well as it should have been, in my opinion. But this has been looked at, and it seems to work. It does reduce the risk of recurrence of UTI if people take a little bit of antibiotics every day, at least in this one big fat meta-analysis, both microbiologically and clinically speaking. Antibiotics work until they don't. And these particular trials were not really designed to look at those ramifications, the ripple effects, the unintended consequences of continuous antibiotics, both harms to the patient in terms of side effects, but also their resistance profile over time. Nevertheless, if you reach for this, which you may choose to do, I would consider that you, number one, tell the patient as soon as you stop antibiotics, that risk will probably come back. Having said so, in my own practice, when I do this, I will cut this into blocks of time. We're going to do this for 6 months. You need a rest. I need a rest. We don't need to see each other so much anymore. We'll do it for 6 months, and then we're going to stop and reassess. And by the way, during that 6 months, you're going to hydrate. We're going to put estrogen back there. We're going to do these other things that we'll talk about as well. So it's very tempting. Low-dose nitro, low-dose sulfa can be used. I would consider for 3 or 6 months and then stopping and inviting that patient to return. What else can be done? You can acidify the patient's urine. So this product called methenamine hippurate, well, it's what it says, it's methenamine and hippurate, and so when that gets into the body, it splits into organic acids and formaldehyde, and so that's a tough place for the patient to try to grow E. coli if they're peeing acid. So you're trying to make the urine more hostile as a place for E. coli to grow. This is evidence-based. You can see the Cochrane meta-analysis here. The relative risk is substantially lower. It's been looked at and studied in short course. That's frustrating to me because I want to give something that's durable and long-term. Data are not there. My own clinical experience, anecdotally, is that there are some patients who really benefit from this. The biggest side effect that they complain of is what you see on the screen. It burns when they pee because they're peeing acid. And they came to see you because it burned when they pee. So for some patients, they're not clear that this treatment is better than the disease. But it is something to consider in some patients. It has helped me with some of my patients in the past. And it's also evidence-based. So the more recent trial that has looked at this is called the ALTER trial. These are patients who either got continuous antibiotics or they got methenamine. Open label. It was not a perfect trial, but there was no difference. As you can see in the bar graphs, there was just no difference between either taking an antibiotic pill or acidifying the urine. So this is a recent publication. Very exciting. It tells us that what we've been doing for all these years actually has more solid evidence for it. And for your patients who want something to reduce their risk of UTI, they've done these other things, but they don't want antibiotics, this is an option. And I think it's underutilized in our practice generally in the United States. Something to consider. Cranberry juice, they'll ask about all the time. The myth of the cranberry is there, and I love when people ask about this. The thought is that one of the chemicals in cranberry, which is called proanthocyanin, that's what makes them look red or purple, that dye, that can stick to the fimbriae, the the hairs on the surface of the E. coli, makes it harder for them to stick to the bladder. That's why E. coli causes UTI. It's designed to hold on to the wall of the colon where it belongs, but when it gets into the bladder, it can hold on to the bladder wall too. If you coat or lubricate the E. coli, that you could reduce the risk of infection. That's the theory with proanthocyanin. And in vitro, it's true. And in vitro is not the same as in vivo. And every time we look at this in vivo, it has basically come up flat in general. There's a company here, I don't have any association with this company, they claim to make the most high potency, pure proanthocyanin, different from the others. And they have graphs like this. What they do not have graphs of is patients' reduction in risk of UTI. I want that clinical information, and I am not able to find that. When we have studied this clinically, there's been no statistically significant benefit in the trials where it has been studied. I think we need a probiotic to put back what was lost. We'll talk about that in a moment. Meantime, we have this guidance from Dr. Anger and others, Journal of Urology. Basically, it says you can offer this to individual patients, but they should not spend too much money. You shouldn't give them a case of DKA from all the sugar that they're drinking, and they should know that it may not work. But it is something to offer. And I have offered this to some patients, and for some patients, they feel that it has made a difference. What about D-mannose? D-mannose is a sugar. Why would you give someone sugar? Well, it's not sucrose, it's mannose. And the D-mannose is thought to act in a very similar way to the proanthocyanin from cranberry juice, coating the lining of the bladder, the transitional epithelium, coating the surface of the E. coli to make them less sticky, less like Velcro, and more like a lubricated goo. And so it's been studied. Here's 300 women in Croatia with recurrent UTI, randomized to getting either nitro or D-mannose. And then they were followed for recurrence of UTI at 6 months. And what they found was that the D-mannose, had a risk reduction, which you can see there, and so did the nitro. It actually seemed to be a little bit superior to the risk reduction, or very similar to the risk reduction with nitro. Nitrofurantoin looked a little bit better, to clarify, but there was still some benefit to D-mannose versus observation over time. So this is an option for some of our patients. It's not a medication. I'm not even clear that you can prescribe it. It's a food. It's a food supplement that they can get online or at a health food store, just like the cranberry juice. And the dosing is, as you can see here, 2 grams a day. When I do this with patients, I'll have them start a little bit lower. It can cause gas, bloating, so I want them to build up something of a tolerance to it. And with that in mind, most of our patients do tolerate it fine. Don't overpromise what it's going to do, but in combination with other factors, it may make a difference. What we have done with antibiotics for respiratory infections, for pneumonia, for skin and soft tissue infections, is we've actually been harming the microbiota of the body. I think we're all confident and comfortable with C. diff and what we're doing with diarrhea. I just want to point out that in the reproductive tract of women, there is also a healthy microbiota, and it is also nuked. When you treat someone for sinusitis, you are killing off their beneficial microbiota in the vagina especially. And so what we call here the Firmicutes group, this is really lactobacillus. The vagina should have a huge predominance of human lactobacillus, not lactobacillus GG, not lactobacillus inners, not lactobacillus that you could get at a health food store, but lactobacillus crispatus and inners. These are human lactobacilli. You cannot buy these at a health food store. There is a company that makes them in California called Ocell, and they're fabulous, and they have a phase 2 clinical trial that showed that when you recolonize patients with recurrent UTI, you can cut their risk of recurrence by 50%. It works. It is not FDA approved. It is not yet available. It is super duper frustrating for me. So that's what I'm trying to show here, that the benefit of these human probiotics is wonderful. It remains experimental, but my hope is that we will all have access to this free, beneficial, very rational technology in the near future. We've been waiting more than 10 years for that to happen. It still has not. What about a vaccine? Why not just give someone a vaccine against this? A vaccine against E. coli? Actually, yes, this does exist. The rationale is not to make an E. coli vaccine, but a vaccine against the uropathogenic E. coli. Not all E. coli are made the same. You've heard about diarrheagenic E. coli, ETEC, O157. Well, there are also uropathogenic E. coli. When patients come in with recurrent UTI, they probably have one of these uropathogenic strains. Why are they uropathogenic? Because they have fimbriae, the little hairs on the surface that are super sticky, and other virulence factors. So there's a company and a group in Europe Germany, as I recall, and they have created a vaccine against those uropathogenic factors on the surface of E. coli. And people have been trying this for a long time. Strovac is the most recent flavor of this vaccine. It is deployed and available in Europe. Today, there are women in Europe who are getting immunized against recurrent UTI. That does not exist in our country. There is, to my knowledge, no FDA-approved trial that is even ongoing as we speak. Having said so, it's actually kind of interesting, and you can see some of the results that we have here. These are patients who were followed over time. The numbers are small. It's 124 women who were enrolled in this particular trial, but as you can see, it looked very similar in terms of benefit to comparing with women who got recurrent, persistent use of antibiotics. So if you had a choice between giving someone a vaccine and making them take a pill a day for the next year, a lot of patients would probably choose the vaccine. And so my hope is that we will get more information about vaccines for UTI, look at the literature, especially coming out of Europe, and if that does come to the United States, perhaps you would have patients you could enroll in such a trial as well. If you're stuck and you're working with a patient, you've tried what you can, and they just don't get better, you may need help. Do not hesitate. And that could be me. I'm an ID doctor. You could send them to me. What you really need to do, I think, is send them on to a urologist or urogynecologist. They may have an anatomic issue with an atonic bladder. There may be a prolapse that's involved. There may be some reason why they cannot drain their urine effectively. That could be part of the issue. I think the simple thing to do in your own office would be to check a post-void residual, either with a catheter or with an ultrasound machine, if you have access to that. That's the first thing that the urologist will ask about. What's their PVR? They've got a PVR of half a liter. Well, there's your problem. But if you are able to do this and that leads to no answer, or you do it and it is normal, you may still benefit from having that person see a GYN who specializes in urology. Don't hesitate, because it would just be terrible if they had a bladder tumor that was in there or something else that was important for their health and that could help to actually get you source control. Having said so, in my own experience, when we do put a camera in the bladder, it's uncommon for it to reveal the answer. But if you've got that one patient who is driving you crazy over time, consider getting help from ID and or urology. So all of these are put together, and again, you've got access to all these results. I won't go through this, but this is a simple algorithm, which I like a lot, from the Journal of Urology, how to think about patients with recurrent UTI. It's a decision tree, a mind map, if you will, and a flow chart. It's what you're already doing. It's what we just talked about, but it does it in an organized way. And frankly, I think the benefit of something like this, it's not just for your own practice. Show it to the patient and go through it with them. Check this off. Print it and put it in their, I guess they don't have charts anymore. There should be a way for people to actually look at this and say, what have we tried? Where are we? That way you're on the same page as your patient. I think partnering with them can make a huge difference. I was asked to talk about catheters, and what is this? Foley catheter? No, it is a one-point restraint. It is a tool of oppression. This is a real problem in our American practice. We tend to use too many catheters. They have all kinds of problems. Please only place Foley catheters when required. When you do, the single biggest factor that leads from Foley catheter to infection, it's that the catheter's not secured. And this was never explained to me when I was in med school. That balloon that keeps the thing from falling out, it rubs against the trigone of the bladder. So if this person, if it's not secured, or it's a male, God help you if you have a man with a catheter. They always fiddle with the catheter so bad. And that balloon is just going to rub away the healthy transitional epithelium. All of these patients are colonized. 100% of them have bacteria in there, period. It's fine. As long as the epithelium is healthy, there's nothing for it to stick to. So when it's not secured, there's a dude who's fiddling, or they auto-terp, it gets caught in the wheel of the wheelchair, they're going to a CAT scan and it just pulls out. That's bad news, and that's when you're going to get in trouble with respect to UTI. So condom caths are good. The pure wick technology I like, which especially in women patients should really be used much more frequently. Know who has a Foley, why, and make that part of your checklist. Let's get it out of these patients as soon as we possibly can. So it's one of my axioms. Time plus tube equals trouble. Doesn't matter whether it's Foley catheter, endotracheal tube, central line. Disinvade our patients as soon as we can do. And again, is it catheter-associated UTI or is it asymptomatic bacteriuria? WTF stands for Where's the Foley? Does the patient even have a Foley? It's hidden under the bed. It's on the other side of the bed. It's amazing at our own university how often people don't even know who's got it. Where did the bladder come from? It's like the immaculate intubation of the bladder. No one knows where it came from, why it's there. Get it out whenever possible. So what about delirium? We talked about this briefly before. If you are skeptical that your patient who is delirious may have a catheter-associated UTI, I think that you're probably right, and we do have national guidelines from the ID Society of America. I am a card-carrying member, and what they say basically is please look for other causes. When it comes to delirium in your catheterized patient, think about medication, 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 then other infections, then medications, and then UTI. Because again, the catheter specimen will not answer your question. Bacteria will be there. We get led down this incorrect pathway, thus C. diff rates rise, at least in my hospital. What about a patient who's in a nursing home? Could this relate to patients who are chronically catheterized in a SNF? Yes, same story, and we do have guidance from people who think about skilled nursing and assisted living patients who are catheterized, same exact issue. So we call these, as you may have heard in antimicrobial stewardship, our 4 moments of antibiotic stewardship. We have these 4 moments. Does my patient have an infection that needs antibiotics? If so, did I get cultures so that I'll have an exit strategy to get out of this? Finally, let's look at those cultures. Let's look at the data. What's this turn out to be? Is it cancer? Was it a heart attack? Was it a PE? Was it an infection? And if so, what do we do as our next step? And finally, duration, which I think is the last frontier of antibiotic stewardship. How long to go? Not just spectrum, not just dose, duration. And over again, we find, I think, Dr. Lewis will agree, that less is usually more. So in the case of UTI, it's a classic. That's exactly what we're talking about. Is it UTI or is it ASB? They all have colonization if they are catheterized. And so we need to be thoughtful about not jumping to that culture because they're delirious or because the urine looks a little cloudy or because the smell when the medical technologist was changing the bag, they said, oh, urine smells bad. Take a big picture, look at the patient. You are their physician. Decide if you think they really have an infection. If they do, treat them. But if not, hold back. And it's not going to be the UA that gives us this answer, as we talked about. And I'm going to skip through this information about culture, which you can look at later. So I think we should test shrewdly. UA first. If the UA is abnormal, proceeding to culture is reasonable. I would usually not do so if the UA is normal. The only exception would be your patients who are neutropenic. They cannot mount a white count because they don't have white cells. That's harder. Those are patients living with cancer, chemotherapy. My threshold to culture those patients would be lower, as we've listed here. So that's what this all comes down to, of course, is that if we use something that's too broad of a spectrum, we will get into trouble with respect to resistance. I've summarized these guidelines here for you in one of this manuscript. There's another manuscript here, which I think is good, including some of the references we went through during this talk. When it comes to recurrent UTI, my concluding thoughts are we should confirm that it's a recurrence of a true infection. We should treat per the guidelines that you've got, but always think about prevention. If you're sick of treating with antibiotics, you're probably right, and there may be other things to do on behalf of that patient. For catheter-associated UTI, they're going to have a culture. Is it because they're infected or because they're just colonized? Treat when we can, when we must, but not otherwise. So that's the remarks I had, and I think we've got a few minutes left for questions, if I'm not mistaken. And by the way, if we run out of time, but I do want to stay on time, I'll be here this morning. We can meet at a break, and we can do other questions as well. But thanks so much for your attention. Does anybody see UTI in their practice? If not, where do you practice? And do you need an ID doctor to join your practice?
So I have a question regarding the hippuric acid.
Please.
For long-term care patients, is there any reason to not use hippuric acid and instead give prophylactic antibiotics?
Yeah, thanks. What are the real downsides to hippuric acid? So it works best when the urine is acidified. And in fact, to get the best benefit out of this, you would probably want to give that person vitamin C several times per day as well. So if you have concerns about acidifying someone's urine, let's say they've got a stone where you're not convinced that that's going to be beneficial to them, that would be a downside to doing it. But no, for most of our patients, the real downside is just that it may not be tolerated because of irritation when they void. And that can, of course, paradoxically be a real issue if you're taking care of that patient because they're complaining that it burns when they pee. So that can make it confusing about what to do. If you have a sense that they're able to give you a good history, they're not delirious, but you can communicate effectively with that patient, and they can discern how they're feeling with and without the use of hippuric acid, then I think it's a great way to go, and probably superior to antibiotics, only because, at least in that cohorted living setting, you're so worried about antibiotic resistance that can spread so easily in the group. So I think it's a great option for those patients, unless you can't get that history because of cognitive issues or language barriers or something of that nature.
And also, can you speak about the use of Keflex for UTIs?
What about cephalexin or Keflex for UTI? Yeah, it's on the menu. And I think that for patients who have uncomplicated UTI, we're talking about lower tract disease, much more than pyelo. In pyelo, I'm not crazy about Keflex because it doesn't tend to dwell in the parenchyma of the kidney. But for the bladder, for someone with good GFR, and they can take the pills, I like the idea of Keflex. I know it's a popular option. The only downside to me is that it's dosed a bit more frequently than some of the other antibiotics we use, and resistance. So you'd want to be more confident that the E. coli was susceptible. But especially if you've got an E. coli in the can and you can look on your resistance profile and it looks friendly, I think it's a good option to consider. I would probably choose that over a fluoroquinolone because of safety and tolerability, if it's susceptible.
Thank you.
Thank you. Other questions?
I have a question for you. Thank you so
Thanks,
much for the up-to-date lecture. And actually, I didn't know we even have vaccine for UTI. It's amazing thing. I hope we will have more information from Europe, and then we can do more things.
I hope so too.
Because it's very important to prevent the recurrent UTI. It's a minor disease, but it's really troublesome.
Oh, I think the patient, that vaccine will sell itself in the patients who would benefit from it. We've had trouble getting people to take their vaccines. You may have heard about this. This will be different because these patients will be highly motivated. It's so vexing. Yeah. If it works, it really does require rigorous scrutiny in a proper U.S. clinical trial. But what they've published in Germany looks good. They just need to do more and more and convince us that it works.
I have a question about, I have some patient, they will complain about whenever they have UTI, their nocturia becomes worse. Have you noticed that?
Nocturia,
elderly in their 70s and
yeah, no, I think that's right. When the bladder is inflamed and irritated, it becomes more spastic, right? So detrusor gets angry because of that localized inflammation coming through the bladder wall. So I think that's true. The opposite is not necessarily the case. So if someone tells me that they're having more nocturia, I really want to get to the bottom of that. And I'm looking for other symptoms that would suggest that it could be infection. If it's just that alone, antibiotics would seem unlikely to solve that issue, put it that way. Although it could be, but I'm looking for other things too. But I think that's a true association. Okay, well, that's the end of the time. So again, I'll be in the back of the room, and if you do have questions, just please let me know. Oh, we have 5 more minutes. Okay. They may want to break themselves. They probably have to pee. I've been telling them how to hydrate. Yeah. Do as I say, not as I do. Everybody get a glass of water. Yes, I love that. Hydration, I see all the bottles going up. It's so good. I love that. Okay, good. Well, in the next session, I think we'll talk about antimicrobial stewardship, then a break, and then I'll talk about an update with antibiotics generally as well. It'll be my pleasure, and we'll talk more about some of these other topics too. Thank you so much.